Welcome back to OMFS Essentials. Today, we begin one of the most common and challenging topics in our field, the impacted mandibular third molar. It is the most frequently impacted tooth, and its removal is fraught with well-known complications. To understand how to safely remove this tooth, we must first have an intimate understanding of its complex anatomical neighborhood. In this episode, Part 1, we will focus exclusively on the applied surgical anatomy. 1. The bony anatomy, the weak zone. When viewing the mandible, you'll notice the third molar sits on a thin lingual shelf, while the buccal side is a strong buttressed ridge of bone. The tooth is located at the junction of the thin vertical ramus and the thick body of the mandible. This junction is a natural line of weakness. Compounding this, the bone grains change direction here, from vertical in the ramus to horizontal in the body. A deeply impacted third molar occupies a large volume of this already weak area. The surgical takeaway? Injudicious bone removal or the application of excessive or uncontrolled force, especially with elevators, can easily lead to an iatrogenic fracture of the angle of the mandible. 2. The nerves, the two critical structures. This area is a crossroads for two major nerves. A. The lingual nerve. Location? The lingual nerve lies in very close proximity to the lingual cortical plate in the third molar area. How it's damaged? 1. Incision. Placing the distal relieving incision, the vertical cut, too far lingually. 2. Slippage. Accidental slippage of a burr or sharp instrument. This is especially common if the soft tissue is not properly guarded with a retractor during bone removal. 3. Fracture. The thin lingual cortical plate fractures easily, and the nerve can be crushed or severed by the fragment. B. The inferior alveolar nerve. Location? The IAN lies close to the roots of a deeply impacted third molar. Relationship? It may be variable and must be assessed radiographically. The nerve may simply be near the apices, it may pass between the roots, or it may groove the surface of the root itself. The surgical takeaway? Meticulous radiographic assessment is mandatory to modify the treatment plan and prevent nerve damage. 3. The vasculature. Bleeding risks. A. The facial artery. Location? It lies at the anterior-inferior angle of the masseter muscle and is close to the buccal vestibule. How it's damaged? The artery can be damaged if the knife slips accidentally during a vertical relieving incision. Pro tip for beginners: to avoid this, a vertical relieving incision should be made from the depth of the vestibule up to the gingival margin, not the other way around. Emergency management: if the artery is cut, profuse bleeding can be controlled with firm extraoral pressure at the inferior border of the mandible, compressing the artery against the bone until it can be ligated. B. Nutrient foramina. Location? Small nutrient vessels are often present in foramina on the lingual side of the retromolar area. Problem? If the distal incision is placed lingually, these vessels can be traumatized, resulting in disturbing intraoperative bleeding. 4. Adjacent soft tissues. The buccal fat pad. Location? It is present lateral and superior to the ramus. How it's damaged? A vertical incision that is placed too far laterally, buccally, or is too long can expose and prolapse the fat pad into the oral cavity. Problem? This is difficult to reduce and can lead to necrosis and delete healing. 5. A note on chisel technique, the stop cut. The anatomy. As we mentioned, the bone grains run vertically in the ramus and horizontally in the body. The technique? If using a chisel to remove bone, you must make vertical stop cuts, cortex deep, at the anterior and posterior ends of the proposed bone removal first. The risk? If you use a chisel parallel to the bone grains without the stop cuts, the bone can split along its entire grain, leading to a catastrophic fracture. Summary: the mandibular third molar region is a minefield of vital structures. Safe removal depends on respecting the nerves, the lingual nerve medially and the inferior alveolar nerve inferiorly, the vessels, the facial artery buccally and the lingual nutrient vessels lingually, the bone, the inherent weakness at the angle of the mandible, the soft tissue, the buccal fat pad laterally. Now that we've established the complex anatomy of the region, we can understand why we classify impactions. In Part 2, we will build on this foundation to discuss the classification systems used to assess the difficulty and risk of removal. You've been listening to OMFS Essentials. Subscribe for Part 2, and as always, keep mastering the essentials.